this presentation is a living document, and the goal will be to make any changes to this so that you can use it. You and Dr. Haugen can use this, Dr. Shriver, in whatever way that you feel it would be appropriate as a representation of um, the project and a summary and an evaluation. So you'll get this PowerPoint after we're done with any revisions you would like made, as well as the one written PDSA models. So you can use it for Joint Commission or patient-centered medical home or quality, however, MOC, whatever you would like to use it for. So our goals today are to go over the protocol and review the implementation data. I'll be able to share some comparisons with the other pilot sites that have wrapped up, and talk about any and many of the lessons learned, and then talk a little bit about sustainability and spread efforts, and provide you with an assessment for completing an evaluation looking towards that. So as you know, you all participated in cohort 2. We hoped to have 4 sites. Our fourth partner had to back out at the last minute due to EHR build issues. But we were really thrilled to have this cohort outside of California, looking at different types of communities, and you all really provided a wonderful opportunity for us to learn what it would look like to screen in an academic medical center. So that was very helpful, and we did see some unique things and learn some unique things from you all as we went through the implementation phase. So a couple of our milestones. You all started, Dr. Haugen and I actually traced back through my emails. We actually started meeting in August of 2019 to work on the EPIC build. Hold on just one moment. Let me yell at the dogs. All right. We were on site training a year ago today. Isn't that crazy? It's funny. It feels like we've come full circle now. You all went live with screening on October 10th, which was exactly what we like to see as a best practice, to go live with screening within a month of training. And then we did work to revamp your EHR report. At first, the data wasn't completely pulling appropriately, so we've got that finalized by December 9th and had our first coaching call on December 19th. I know that we built your documentation in EPIC as a flow sheet, and really had a nice section there where we were able to capture all of the key data points for your outcome measures. I know at one point I heard from you all that the nurses were requesting that there be a revision to the build because I believe it was they felt it wasn't easy to find the flow sheet. Dr. Haugen, is that accurate? Are you able to refresh my memory on that?
Yeah, they had to, because they had to look it up themselves. Like they had to find the flow worksheet, the flow sheet, and then and then like wrench it in, basically save it so that they could always find it. That's not something that people were very easy to do. The good news is that as of 3 weeks ago, we moved it into our Well Child Navigator tab. So now it is underneath there for all patients, and it is just a simple click and enter. So we've actually updated that since then and got it to a place where they're used to entering in all their other worksheets and things like that, other questionnaires.
Excellent, excellent. I would be really interested to see, and maybe you all can just take a look at how, if that's increased your screening rates. We can talk a little bit more about that. That's a wonderful revision. I will add that to this presentation so that we capture that. So in just looking through your PDSA, we started with the target population of 15-month-old and 3-year-old well child visits. And the rationale that you all identified, I thought was wonderful. You really took it down to beyond just saying early identification and intervention, but to really focus on healthy brain development and preventing those downstream long-term health consequences. You started using the ACE-Q parent report. We could talk a bit more about whether or not you'd like to convert over to the PEARLS tool, and the scoring protocol that we designated for your clinic. We set a very low threshold for positive scores because you were screening at such an early age. I think that's one of the beautiful things about the way we implement screening or coach at CYW, that everyone can set their threshold at whatever level they would like. And so you all said patients were an intermediate risk if they had a score of 1 or greater without symptoms, and then high risk with a score of 1 to 3 with symptoms, or 4 or greater with or without symptoms. So again, a pretty intense threshold there, but again, a really great way to approach it with such a young age group. And you also had a very robust stratified referral process. So for the intermediate, you were really looking at Head Start for the 3-year-olds, and I have to say, hooking the family up with the connections, because I want to say connecting people with connections, but that doesn't sound right, for more of those social determinant types of needs. And then you had not only the integrated behavioral health team in-house, but you also had external mental health professionals for some of those high-risk patients. So you really had one of the most robust referral networks of any of the cohorts that we worked with in this past year. Just a quick reminder of the process that we had outlined in the beginning. I know this may have changed a little bit, so we'll want to be sure and capture that. But the clinic staff were handing out the What Are ACEs patient ed sheet with the screener and introducing it to the parents, having them complete that in the exam room, and then handing off to the medical provider. The 4 measures we were looking at were the percent of patients screened, and that was based on eligibility for screening at a well child visit for 15-month-olds and 3-year-olds. We looked at the percent of patients who had a positive score. Now, I do need to clarify something. I looked back through our training presentation, and in the presentation, it said we were tracking patients with a positive score, meaning intermediate and high. But in looking at your data, I don't believe that could possibly be accurate because the numbers are not high enough for us to look at both. And when I look back through the data I was getting, it really does look like it was just the high risk patients, which is typical for what we measure. So I just needed to correct your training presentation, but I did want to clarify that here. I see you nodding, Dr. Schreiber.
Yeah, that's correct.
Okay. All right. And then we looked at the number of patients with an appropriate referral. One caveat here is we did subtract the patients that were already in services that you all had probably intuited or were outright made aware that they needed assistance or needed some type of services prior to screening, just through your normal clinical judgment, so that we subtracted those off the denominator so that it didn't give you an inappropriately low referral rate. And then we looked at the number of patients refusing. So here's a little picture of your data, just a simple graph here. I don't want you all to be discouraged by your screening rate because there are some really key things here. So, you know, I'm very happy to, we can talk about how we might want to represent this differently if you're using this for other audiences. This is just for us talking today, so I wanted to give you the data as it was reported. You all screened the highest number of patients by triple of any of the other cohorts or pilot sites, excuse me. Actually, I mean, you all screened more patients than any of our pilot sites, even in cohort 1. So you screened almost 400 or a little over 400 patients in 6 months. You had 9% positive. We talked a little bit about during coaching calls, you feeling like that might have been a little bit low, but again, I think for the age group that you were screening, that's probably very accurate. Yay, that's good. I mean, I always have to remind people, it's okay to have no ACEs. It's just probably going to be unlikely by the time you're an adult, but it's great.
Well, and Carissa, I think it's so great to be able to see this data in a graph form, because I think it generates a lot of hypotheses and theories about why the data are the way they are, and you know why we're 9% positive. And you know, part of it is the age group. Maybe they haven't experienced life enough to have enough ACEs, but also how are we doing with presenting this form? Do people feel comfortable disclosing their ACEs or not at this stage? Is another question. You know, like, were people honest or not honest in their ACEs reporting? I certainly can think of a couple of patients who put 0 who I'm like, I'm not sure it's 0. So I think that it's so important to just honestly report the data and then just really ask the questions about why we're only 9% positive. Is that what we see in that age range in general, or is this a difficult form to elicit information, or is the approach, are we not, you know, are we explaining the form well enough? Are we giving them, you know, a comfort level that's good enough? Or so I think really a great piece of data and really important to ask those questions. So I really love that. And I thank you for the information about how many patients that we had screened. That was a surprise to me. That, you know, I'm not surprised that the screening percentile is low, and I think it's a good question to ask. And I think one thing that you and I saw over the time is that we trended upward in our screening. But it's still really honest data to say this is the percent we screened, why is that? And there are a lot of great answers to that too. So I know that part of this pilot was to create a learning opportunity, and how can we do this and how can we do it well, and what are the barriers to screening? And boy, I think we've generated a lot of answers to that question.
Yeah, I want to make sure that I add this. I wrote it down today to add, and I forgot to do it. But you all doubled your screening rate from, I think the first month it was like 27%. By the end, it was almost 80%. What happened was that averaged out to 43, but you had a huge surge. So a wonderful show of enthusiasm and recovery, I guess. I know that you and Dr. Haugen went and spoke to some of the providers that were a little bit more resistant, and that was also a very unique thing. Most of your providers screened fairly consistently, but you had one or two that were super resistant. So, and I know we talked back and forth about taking them out of the data or keeping them in, and so that's something we can talk about further as well.
Well, and I think that would be a really great graph to include, is just our improvement over time. And
Yeah.
I might even be able to assist in inserting some arrows in the timeline because of the other barriers we encountered, like our our construction and our move, which kind of threw us for a loop, and then
Yeah.
COVID arrow and things. So that explains some of the data. So I think that would be a beautiful graph to include, is like how we were slow like turtles to get started, and then how we were able to pick up. And that's where we learn a lot, is how do we get better with this, and what were the interventions that made us better, and what were the barriers. So terrific idea.
Yeah, absolutely. I can absolutely put that together. I You guys had a very high referral rate of those that were positive, which was wonderful. That happened very consistently. And I'm not surprised about your refusal rate being about 20%. You also mentioned you had a lot of staff variability from the clinical staff, I guess the nurses and the medical assistants. And if they're introducing the tool and they're not comfortable with it, we see this type of this kind of higher refusal rate. But all in all, that percentage is not horrific. I mean, many clinics experience about 20% refusal. I just pulled this slide in, which was one that Murnell was able to put together for us in the training, just to show, just to glance back at some of the Iowa data. Now, this is all ages, so this is 0 to 17. 24% of kids had at least one ACE. So, 9% is really not that crazy when you think about the small population we were assessing. I mean, it may be a little bit low, but it's not that far off track. I wanted to make sure that we captured some of the things that were occurring. And like I said, you screened over 400 patients. We trained 12 providers that I think we had 9 at one point, and 10, and at one point there were 12 providers screening. You had the highest number of patients screened, and you had the largest number of provider screening. So you had the busiest clinics. We saw a significant decline after the COVID pandemic. You weren't doing the 3-year-old visits anymore, well child. You were doing those more telehealth. So you lost a huge segment of your population, and yet your rates surged. So you really did get your processes established. I mean, there's no doubt the clinic remodel project was very disruptive to your implementation. I I didn't anticipate that it would be so disruptive, but as you all described it, I could just imagine. I mean, I thought, wow, maybe we shouldn't have started this because it was just a really challenging thing. Um, Having the staff say, we don't know where the papers are, we don't know where the handouts are. I mean, every day you were kind of moving from pod to pod. So it is very challenging to have a consistent process when you're moving around like that. And so I think also, as I would like to know when the project wrapped up, or is it still underway?
It's wrapped up. Eric, when was our kind of cutting the ribbon date?
I may have lost him.
Yeah.
I bet you that's what.
Oh, no,
Also,
nope, sorry about that. Your ribbon cutting day for the clinic or for the pilot?
For when we were done with our remodel.
The last day was 6/14, so June 14th.
Okay, and I have data through April, so and you had already started improving, so I would suspect now it's much different. I bet your rates are much higher.
Yeah, they
And
probably are.
and then the staff variability. Dr. Shriver, I think this, I don't know if that was just because of the move or the clinic remodel, but you all were having different nurses come float in and out, and that seemed to be a barrier too. And maybe this is a good uh, way to talk about having dedicated staff, or at least an argument for that.
Yeah, there's a lot of reason for staff turnover, and it is incredibly great teaching point as you move forward. So I think every barrier is like an opportunity to learn. So if you recognize that staff turnover is an issue, then making an effort to maintain staff will help you with your overall outcomes for your patients. And also the importance of continued education with new staff as they come in is something that you take away from this too, I think.
Absolutely, absolutely. So I wanted to just share a couple of thoughts. In 2017, uh, we at CYW wrote a white paper looking at the key considerations for assessing whether or not a clinic was ready to spread their screening efforts or they needed to focus towards sustaining their current processes and refining them and going through another PDSA cycle. And we identified 3 domains and 6 factors that really led to a greater potential to really spread efforts. And so we have an assessment that is a written assessment that I would be happy to go through with you all, or I can provide it to you for a self-assessment. But we looked at the process factors, how well you were able to innovate and adapt, and how easy it was for data collection and measurement. The staff factors, so not only engagement and training of staff, but also leaders. And then the organizational fit. How did this project align with other strategies, and what types of infrastructure do you have? I have just a few things here that I noted, but I've already thought of several more that I need to add. From a preliminary assessment, I brainstormed for about 30 minutes on some of the things that I saw and heard from you all through the coaching calls. There was clearly one of the most innovative processes we saw for addressing screening needs for non-English, non-Spanish speakers using Stratus, where you would hold the screener up and they would translate that. I've shared that with lots of other clinics. they've been very excited, like, oh, that's a great idea. So also, I mean, just the adaptability you all had to come up with during the clinic renovations. Staff, oh, and also the fact that your your data reporting, once we got it refined a little bit, was very robust. Like we could see which providers were screening. You had the most robust data report of any of the sites, and it seemed to be fairly easy to pull, and very easy to read and navigate. The
It
staff
sounds,
fact. Go ahead.
I was just going to say, it sounds like our data puller needs a Focus Award, right, Eric? She worked really hard to get us that data. So
She did. She did.
And she has retired, hasn't she? Or she is retiring?
She is retired, so she's in the process of retiring, finishing up some last few things. So I actually reached out to her today to find out. I was looking to see if she had passed that along to anybody on how she was pulling the data, and she had not yet, but she will be, so we'll be able to continue to maintain access to that data.
Great, great. She was wonderful to work with. Donna, right?
Tony.
Tony, yes, Tony. Great to work with. Okay. From staff factors, I put that the nurses provided feedback regarding Epic with suggestions for improvement, and I can add here, and they've already been implemented, so that's great. So you are also the only clinic that did enhancements to your build from the original implementation. That is always a challenge with clinics. That's one of the key things that we've identified as a barrier to successful implementation. That's why we start the EHR build so early. I mean, we were blessed that Dr. Haugen has the Epic expertise, and we love that you're a weirdo for Epic, right? Because that enthusiasm, I think, gave us the opportunity for you to have changes and to have your build done well, and with some oversight and with a little bit of pressure there behind it. So that was a wonderful thing. And then you've already used the discussions with this, and I know you've presented other places, Dr. Shriver, some of your findings and some of your work. I mean, you're kind of getting to be an ACEs rock star out there in the community, so we love that. And you guys have already used this and some of your other wonderful achievements to get additional funding. Now, I knew it wasn't, it's a Sesame Street community, right?
Oh yeah, this is new. So it's not just through our clinic, but in the Des Moines Metro, and really possibly spanning the whole state now. Bringing in Sesame Street and communities to our area, and really working on talking about early relational health, dealing with stress, supporting children and families in their home and communities. And so it definitely aligns well with prevention of ACEs, and then early intervention, mitigation of some of the stressors that go along with ACEs. And it's really, I can keep you guys kind of in the loop as this progresses, but we're hoping to produce some resources that are not only able to be utilized in our own communities, but anywhere where you care about early relational health. So we're hoping to produce some videos out there with the Sesame Street stars, and so it's going to be pretty fun and interesting, and it's definitely targeted in the same zone of not only the adverse childhood experiences, but how to promote those positive childhood experiences, to kind of turn the framework on its head and thinking about, supportive things we can do. So that's really, really exciting. It's only it's including our clinic, but not just limited to our clinic. So really exciting.
Any way any way we could help you all integrate the domains of wellness into the Sesame Street communities, I think we would all be thrilled to see, you know, kids all across America be familiar with the term domains of wellness or building resilience. So we love that. We too are wanting to focus more on that
I
in
love
the coming year.
I love the domains of wellness, and I use them every day in my clinic with the CC123 model that has kind of been really useful, especially during COVID. So you mentioned that although we saw fewer patients during COVID, we still were really emphasizing the importance of ACEs screening and emphasizing the talking points that have to do with stress. And
Yeah.
now more than ever, families are understanding what stress looks like and understanding why everyone needs to talk about stress and how we need to become better managers of our own stress and the stress of our children. So this has made the discussion of ACEs and stress, whether it's toxic or non-toxic, extremely well received among every single person that walks into our clinic, whether it's our staff, our providers, or our patients. Like, everybody understands stress right now to a level that we've never understood it before.
Yeah.
And in addition to just having our handouts, which are beautifully designed and just well received, and our screening, which is so important, and our overall social determinants of health screening, which has played an important role in the COVID era, but also just our model of CC123, talking about positive parenting, forgiveness and grace and love during the time of COVID. So I usually use that the first C coping, or the first C is connections, the second C is coping. And when I talk about coping, I talk about the domains of health, and I make sure that parents understand what kids need always, but especially during stress. And the domains of health are an incredibly helpful framework to let people know. So I think going forward with Sesame Street, the way that you guys can help is to, if there are just kind of useful documents that are designed by you that just are hey, these are the domains of health we all need to be sharing with kids and families, making sure they're hitting all these targets every day to maintain health and well-being. I definitely see that as a key player in our efforts with early relational health and dealing with stress. So I love the domains, use them every single day, talk about them all the time. I think I just gave a talk with the Des Moines Public Library about COVID, that always the domains are there. So
Yeah.
for sure, going to be useful. We can definitely reach out to you when those conversations happen about tools that we're using.
That would be wonderful. Wonderful. That is exciting. My slides are frozen. Let's go. Keep going. Let me see if I can get it to. There we go. So our next steps, we'll finalize this presentation and send it to you. And it will be a PowerPoint so that you can change it and edit it and take slides out or add additional things. I will add the slide documenting your timeline, and I'll capture some of those points in specific time where things changed and occurred. I think that'll be very telling and helpful to complete the whole story. I can also send you the sustainability screening or the sustainability and spread assessment. If you guys decide you'd like to go through that with me, I'm happy to set up a time to do that. We have our last kind of learning collaborative call on October 15th. I will have completed all of these summary meetings with the other two clinics. So we'll be able to share a little bit of comparisons and see everybody's data on that call, and I'll provide you a written summary of that. And the direction we're going now with CYW is really not to just do screening pilots any further, but really to look at doing more of an ecosystem pilot where we not only look at the clinic and certainly start with the clinic and screening efforts, but look at the full community approach to ACEs and trauma. And so thinking about trauma-informed training for community centers and schools, looking at a community care plan where you involve either a technology-based platform for community referrals or like Unite Us or One Degree or Aunt Bertha, but also looking at ways that we have resources based on the 7 domains of wellness for community members. So when we talk about being in nature, that there's a list of parks or hiking trails that families know about and can become more aware of, so that they access them and get a 2-for-1 benefit of being in nature and a little bit of exercise. So really focusing on ways that we can build resilience in the community. And then also thinking about building a community stakeholder group or a coalition, resilience coalition or ACEs coalition. We like to see resilience coalitions being built, again, to focus more on the positive aspects. And then that would eventually lead to changes in policy and additional advocacy in the community, where we make sure that our police force is trauma informed, that they understand ACEs, that it's not enough just to teach de-escalation, but really having an understanding of stress and toxic stress and trauma, and how to not re-trigger families or individuals, and then all of that leads back and feeds that clinic and community partnership. So Molly is really taking the lead on building these ecosystem models. We have a couple of projects in cities and in communities across the country, but we're always looking for more opportunities, because each ecosystem, while there are some core components, they're always going to be community based and community focused. So they'll all have a little bit of a different flavor based on the community with which they're being implemented. In addition to that, something we are really proud of is we have taken the learning and the training that we have been doing with the pilot sites, and we've created 4 learning management online courses that are available for purchase. They have both CME and MOC credit, so we're happy to share those with you. And if you have, I know Dr. Shriver, you're very active in your state chapter of the AAP. You're in leadership there, correct?
Yeah, I'm on the executive board, as well as I'm the early childhood champion and the chair of the mental health committee. So
Wow.
all are kind of aligned together.
Great.
Chapter. So
Yeah.
we have multiple roles.
Yeah, just a little something else to do in all your free time. So the learning management courses are really, during COVID, we've seen a dramatic decrease in donor giving, as I'm sure everyone has. So that's kind of been our strategy to create some revenue so that we can attend to our mission without damaging our margin. But we think that given the fact that there's CME related to those courses and MOC credit, that those would be useful to providers who are interested in learning more. And so we we would love to talk to you further, Dr. Shriver, about.
Right. Yeah. Send them my way, and I will disseminate. And I can even kind of send them to the Council on Early Childhood to see if people would be interested in that, because I feel like that is a great target audience as well. And we
Yeah.
have a wider reach than just our state. In addition, Molly, maybe you and I could touch base a little further later about if you'd want to be looped into any of our Sesame Street and Communities meetings, because I think it aligns with your ecosystem planning. Because, you know, when you were explaining what a community that's trauma informed looks like, it makes me reflect on what happened after Paper Tigers came out in Washington, and how the whole community really had a deeper understanding of ACEs and their impact on children, families, and communities, and how it really expanded awareness and willingness to kind of jump in at different systems levels. So I see that as what will hopefully happen with our Sesame Street and Communities as well. It's a way to be engaged in multiple systems across the metro and maybe the state, and really create that kind of training and awareness. So Molly, talk to me later if that's something you want to be looped into, just to kind of feel out what's going on there in terms of planning. I don't have a date yet, but will be coming up soon. And, you know, I think it aligns well with what you're doing. And I would also just really, I mean, you have probably multiple ways of thinking about ecosystems and engaging in this work, but I always like to slip in a partnership with Reach Out and Read, because, you know, pediatricians are the gateway to these families in the earliest ages, and we already have a network across the country of pediatricians talking about positive childhood experiences, including shared reading, which there's tons of evidence to support. So when you're planning your ecosystem, don't forget about the power of the network of Reach Out and Read that we have, and how much benefit that can be in kind of the target audience that you have.
Yeah, I think that's great. I would love to be part of the Sesame Street calls whenever they happen, or those meetings. You know, I'm happy. I know that they'll send out, Mernell and Krista will send out information. My email will be in there. So please, you know, feel free to loop me into those, or I can write you a separate email if that's easier. And yeah, and the suggestion of Reach Out and Read is great. I can, that's a really good way to connect with pediatricians. So I will take a look at that. Thank you for the suggestion.
Yeah, that is a great suggestion. We actually have a clinical provider working on a book, Dr. Shriver, about ACEs and resilience. So a cool story, and it has even a little COVID twist. So it's we're excited about that, and we're looking forward to that being published, and we'll let you know about that as well. All right. Do you, that is the end of my presentation. Do you all have other thoughts or questions that you would like me to consider, or any additions that we did not discuss in this presentation?
I would say it's up to you whether you think this is a valuable thing to include, but I think one of the most valuable things I learned from doing this was that even if we have 9% positive, that the action of screening validates the fact that stress is real, and that it's important to talk about, and that it's important to address and treat. We saw it as well received among all of our families. We didn't do a formal, you know, questionnaire about how, but every time I screened, I asked the families how they felt, and everybody said they were happy to be screened. Some people felt like they were just relieved that they didn't have those ACEs, and some people felt, so there was relief, gratitude, and also just appreciation for the fact that we're looking out for families, not just their family, but all families, to talk about this. So it was, I think, to say the benefits of doing this screening are that it's not only well received and creates some positive emotions among our patients, but also that it in some ways was really a therapeutic discussion. and that people felt like talking about it was helpful, and it is a door opener. So I know that there's some that providers sometimes have hesitancy in initiating ACEs screening just because they're worried about rapport, or they're worried about how it's perceived by patients. So I don't know if that is something that you feel like is interesting to include, but not only well received, but a therapeutic conversation happens most of the time when you introduce this topic in this very structured way, rather than just sort of on the fly or just in an unstructured way. So, and it's a validating process, and I think that people really need to know that it's not just about the numbers of patients you get. It's about how patients feel about what happens and how much it opens doors to conversations.
Absolutely. No, that is a great point. I I think it's very important, and I saw in my notes from our calls that you said that their families actually expressed gratitude for talking to them about screening. And I think, it's without a doubt reinforces the 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 patient provider relationship, that this is a medical home where you come here when you're sick and when you're well, and we will work together for you to have an opportunity to be as happy and healthy as possible. um, in some of our early work and study around screening, we did some patient focus groups, and they felt that the screening itself was an intervention. And I appreciate that you reminded me of the reality of that, and that we're hearing it echoed in your community as well.
I think that depending on the audience for this presentation, if the idea is to motivate more screening out there in the world and showing how beneficial this screening pilot has been to our patients and families, I think it's just really great to say, hey, whatever fears you had going into screening, you shouldn't fear, because it's largely not true that patients don't like the screening. They do, they benefit, it's therapeutic, it is a framework for opening up important discussions. And so I know there's just a lot of discussion out there about screening, and I feel like the study has really helped us feel like it's helpful.
Good, good, good. Any other thoughts or comments? I know we're about out of time, but I will revise this presentation, send it to you, as well as the one-page PDSA, which is just like an executive memo for you to use however you see fit. Those will both be in editable format, so you can change anything, or add additional thoughts however you would like to use it. It would be just fine with us. And if you find some valuable avenues to share this information, we'd love to hear that too. How it's useful, that would be great.
So once you send me the final copy, it is okay to present to different organizations, and you want us to notify you if and when we do that. Is that right?
That would be great. Yes, thank you. Yeah.
I could see it being a wonderful grand rounds. I know our hospital would love to know how things went, and possibly there are other opportunities. I know a lot of organizations within the area would be interested. I often get contacted by DHS and NAMI, our state chapter of NAMI, and they would love to kind of hear this too. So a lot of systems out there would be interested in knowing this data. So Thank you for putting together such a lovely presentation. It was really important data that's out there, and real and true. Not all of it makes us look awesome, but like I think we worked hard, and you were such a great coach in helping us do better. So I really appreciate all of you and all the work that you've done, and that you stuck by us in the good times and the bad.
Well, you all were a pleasure to work with, and really truly, the work that you do and the volume of patients you see, and your dedication to screening was inspiring. So it was very easy to work with you, and it was a lot of fun. This is this project is one of the things I'm most proud of, and the opportunity to work with you all. So thank you. I'm going to miss our coaching calls, but I'm here if you need me or if you have questions, please don't hesitate to reach out to me.
Well, and I hope we get to work together in the future. I think this is just a door opener as well, because you guys are doing such great work there. And, you know, we're constantly interested in the new innovations. And Molly, I look forward to, you know, what your ecosystems work looks like. And Murnell, you may want to take CC 123 and run with it. It's not copyrighted really in any way, but it's really useful for providers to talk about stress. So I'll send it your way, and probably later today.
Great.
That'd be great. Thank you so much, Dr. Shriver. I think, and Dr. Hagan for joining us and for being here.
Yep. No, it's been great to work with you all.
Thank you. And I could also share the recording once it's ready so that we could have it for reference. We can cover what we talked about here as well. Yeah.
All right.
Awesome.
Thank you all. Have a
Thank you
wonderful
all.
day.
Bye, guys. Thanks.
Bye, everyone. Bye.